Hi, Adult Health 1. So this is Module 8. There's two parts to this. There's Module 8A and 8B because this is GI disorders. And there is a lot of GI stuff. So this is Chapter 55, which is Assessment of GI. 56, Oral and Esophageal Disorders. 57, Stomach Disorders. And then 68, Obesity in Adults. These are our objectives. All right. So GI tract, also known as the alimentary tract, begins in the esophagus and ends with the anus, right? It's this big old long tube that just runs right down. It's responsible for digestion and absorption of nutrients and expelling metabolic waste. The tract consists of the mouth, pharynx, esophagus, stomach, small intestine, and large intestine. Just goes all the way down. Um, Teeth, tongue, salivary glands, liver, gallbladder, pancreas, they all help in the digestive process. And we've talked about pancreatic enzymes before, right? Um, so GI assessment is included in either the routine physical or a problem-focused exam. Focus on the collection of objective data. Physical exam includes direct assessment of the oral cavity, right? Because if somebody has something related to malnutrition, do they have teeth? You know, do they have pain? Do they have sores in their mouth? Is there a reason maybe they're not eating? Um, we're also going to look at the skin. And then we have an indirect assessment of underlying structures. So intestinal tract, liver, kidney, spleen, abdominal arteries, like all of that stuff is an indirect assessment. So first we're going to auscultate, basically bowel sounds. You know, you did that in fundamentals, right? All four quadrants. Let's see. So, hold on. I'm reading and taking it back. So we don't forget when we are talking about GI stuff, percussion and palpation occur after auscultation, right? Normally they come before, but with GI, percussion and palpation come after auscultation because we don't want to like move things around and change the sounds that we're hearing, right? So like potential manipulation of abdominal contents. So we auscultate and then we percuss. Um, This is a big old long thing about what you might hear while you're percussing, just dullness versus if you have like fluid in the stomach, you know, like ascites, you know, it's kind of a dull sound. But honestly, you're going to look at somebody with ascites and they're going to look 9 months pregnant and you're going to have no question. And then palpation. So we auscultate, percuss, we palpate. Okay. This is a slide table 55.2. These are just some of the questions that we ask during a GI assessment. Notice, you know, we're talking GI, right? So dietary practices are huge related to GI because whatever we're eating can irritate or not irritate our stomachs, okay? And then, of course, like we talked about oral health, you know, do they have pain? Do they have sores? Do they have teeth? Do their dentures fit appropriately? You know, are they able to chew and appropriately swallow their food? And then, of course, preventive health, which we want to ask about anyway. And then weight changes. You know, if somebody is not on a diet, like not purposely trying to lose weight, but come in, you know, maybe they've lost 10 pounds in the last 2 weeks. Something's going on if that was non-intentional, okay? These are some other questions. Appetite changes, stool changes, right? A lot of GI things, if we have any blood, you may see blood in the bowel. If somebody is no longer, they used to poop every day and now they're pooping every 3, you know, what has changed, right? And then, of course, pain. This is just a nice little diagram out of the book of the quadrants, and then where things are located. All right. So just take a look at this slide. It's slide 6. This talks about ostomies. You know, when we get into GI stuff, people can, if they're having bowel issues, can end up with an ostomy. This is inspection of an ostomy, the 3 S's. We want to look at the skin because you can end up with breakdown either related to the acidity of the stool, or the appliance itself. You know, that's all stuck on with sticky stuff. So you can have breakdown related to the appliance. You can also have like excoriation and stuff. You know, again, it's plastic, it's a plastic bag. That bag could be rubbing against skin and causing problems. So there's a lot of skin stuff related to stomas. We also want to look at the stoma site itself. It should be pink and moist. It's described often like beefy red. If you see fresh hamburger meat or like a fresh steak, honestly, that's what a stoma should look like. If it starts to look purplish, dusky, gray, we are worried about oxygen not getting to that site, and therefore, and that can go necrotic, right? That can die on us, and that's a big problem. And then, of course, the stool. So it's really kind of cool because the consistency of the stool is going to be dependent on where the stoma is located. So the closer you get to the rectum, basically, you know, where stool comes out formed, the more formed stool becomes. All right. So so an ostomy located in the ileum is going to be kind of like semi-liquid, whereas a colostomy, a sigmoid colostomy, is going to be pretty much formed. So it depends on where your ostomy is as to what consistency your stool should be. Okay, so we'll talk, we have a nice diagram about that though. We'll talk about it in class. Diagnostic testing essential to comprehensive GI function. Um, you know, labs, blood, urine, stool, right? Stool, we're going to look for blood in the stool, that sort of thing. X-rays are usually great, usually fine. We may do an ultrasound. Um, if somebody cannot handle contrast, because you a lot of times will do barium studies, so the patient has to swallow the contrast, and then you go into x-ray and you can kind of see where things are located, how the fluid is traveling through the GI tract, you know, if we're looking for an obstruction or something like that. Now, the thing is, if we suspect a perforation, then we use gastrogafin instead of barium. All right. So that's probably a thing to know. If we suspect a perforation, we're going to use gastrogafin instead of barium because we don't want barium getting out of that GI system and seeping into areas that we don't want it. So one of the big things when we are talking GI and whether we've put our person completely out with anesthetic or maybe a twilight scenario, whatever, you know, endoscopy, a lot of times we'll just use a twilight. We cannot let our person eat until that gag reflex has returned. All right. Um, so we will know that by maybe ice cubes, tiny sips of water. You know, is our person able to handle their own secretions? Are they drooling? If they're drooling, they're not handling their own secretions, right? You don't expect to be talking to me and have spit coming out of my mouth, right? As spit forms, you swallow it, life goes on, okay? So before we're allowed our person to return to normal, have anything solid to eat, anything like that, that gag reflex has to return. Also, if our person is having contrast related to their procedure, you need to make sure that they have ingested all the contrast and that a diet was followed pre-procedure. The reason that's important is because a lot of times with GI stuff, or like colonoscopies and stuff like that, they have to have you basically empty out the system so that when they go in with a scope and look around, there's nothing in the way of that scope. They want an empty system. So like with colonoscopies, you drink Go Lightly like 8 hours before or the night before, and trust me, Go Lightly has you sitting in the restroom, like just bring your phone, right? Because you're just going to sit there while your bowels empty themselves out. And it's important to make sure that patients did that, because if they did not do the pre-procedure diet, they can't do the procedure. It has to be rescheduled because they won't be able to see anything. These are some safety alerts. Slide 9. Pre-procedural care. Aspiration of barium swallow can cause severe aspiration pneumonia. So respiratory assessment should be conducted in individuals with dysphagia before and after the procedure. So if someone's having trouble swallowing, we want to make sure that they didn't aspirate any of that barium. All right. Post-procedure care, increase fluid intake and/or enemas as necessary to prevent constipation and impaction in patients who undergo barium studies. So again, we're going to want to talk to our person about the importance of pooping. And one of the easiest ways for people to maintain their poop schedule, make sure you're drinking enough fluids, right? Um, the bowel pulls fluids from the body, makes that stool easier to pass, but also maybe using an enema or glycerin suppositories, something like that. All right, so endoscopy. Endoscopy is a general term used to describe the procedure in which a fiber optic scope is used to visualize the GI tract. Endoscopic studies can serve three purposes. They can be diagnostic, curative, or palliative. Patients are sedated with a narcotic and a sedative. The pre-procedural and post-procedural nursing interventions are similar and outlined in Table 55.8. So nursing implications. So verify patient's been NPO. Of course, we want to make sure that consent was signed. And then we're going to do as nurses the pre and post monitoring, right? And then after an upper endo, the nurse monitors for the return of swallowing before providing oral intake to decrease the risk of aspiration. After a lower endo, anticoagulants, and aspirin are usually held temporarily due to the risk of bleeding. Chances are the doctor's orders will also include holding anything like that, maybe before the procedure itself. Because if they go in, like we always talk about, anytime we're sticking a tube in the body, we're going to irritate the body. And a risk is always nicking something, bleeding, irritation, right? So whatever we can do to reduce risk, we're going to do. So nursing implications, we're going to do our focused physical assessment, of course. And like we talked about, make sure that person has been NPO. This slide 11. So these are some procedures from the book. I cut out the ones, copy and pasted the ones that I really want you to be aware of. This esophageal-gastroduodenoscopy, EGD, all right? Esophageal-gastroduodenoscopy. It tells you exactly how it goes. Esophageal-gastroduodenoscopy. So down the esophagus, into the stomach, down to the duodenum, all right? So that's a scope. It goes down. We can see hiatal hernias, gastritis. You can identify peptic ulcers, which a lot of times is caused by H. pylori. And then if we're looking at in the esophagus, we can see esophageal varices, strictures, tumors, stuff like that. All right. This is another one where we want to be aware of bleeding. We want the return of the gag reflex. We're going to monitor those vitals, all that stuff. And then there's an endoscopic retrograde cholangiopancreatography, ERCP, okay? ERCP. That one goes and looks at the pancreas and biliary ducts. All right. So if our person is jaundice, right? Or maybe our pancreatic labs are off, our amylase and lipase, right? We're gonna want to do an ERCP, go and see what's going on with the pancreas and the biliary ducts. We can identify gallstones with that, tumors, pancreatic cancer, stuff like that. All right. So EGD, esophagus, stomach, duodenum, all those things. Hiatal hernias, esophageal varices. Who gets esophageal varices? My drinkers, okay? Causes a lot of problems in the esophagus. And then my ERCP, that's the pancreas and the biliary ducts. This is just about a colonoscopy. They go through the rectum. It's going to look for colon cancer, polyps, Crohn's disease, diverticular disease, and arteriovenous malformations. You're going to do bowel prep for this 24 hours before the colonoscopy. They have to complete all of the bowel prep. That's the biggest teaching point with this. And that's pretty much it for colonoscopy. This just talks about when we recommend colorectal cancer screenings. Male or female individuals age 45 who are at average risk, and then African Americans beginning at age 45. So, and then there's just some different recommendations related to that. So 45 is when we start recommending colonoscopies for average risk people. All right. All right. Chapter 56, oral and esophageal disorders. So stomitis. Stomitis is an inflammatory condition affecting the oral mucosa, dentition, and periosteum. Known risk factors for stomitis: viral infections, bacterial infections, yeast, irritants, alcohol, tobacco, mouthwash, radiation and chemo, allergies, vitamin deficiencies, poor oral hygiene, right? That's going to be huge. Let's see. A lot of times I have mostly seen this related to cancer patients. All right. And they have different mouthwashes that they put together for people to use. And it just kind of calms everything down. So really the age of our patient, nutrition, type of cancer, and oral hygiene are all going to be risk factors that also play into what's going on with our person. So assessment, oral mucosa, nutrition, weight. Anytime something is wrong with the mouth, esophagus, anything that could make eating painful, we want to think about weight on our person. All right. The mucosa could be dry, red, swollen, maybe even cracked. They could have ulcers, canker sores. They could have bleeding related to this. Obviously, pain if you have all of that going on. And then anytime we have openings in the mucosa, just like with our skin, we worry about the possibility of infection. You can end up with abscesses. So when we are talking about an assessment, we're always worried about infection. So temperature is going to be big, right? Also, do they have a fluid volume deficit? Nutritional intake. Do they look malnourished? Are they tired all the time? What are their labs showing? Eyes and O's. Actions, meds as prescribed, possibly antimicrobials. You're going to have mouthwashes, like swish and swallow mouthwashes to help what's going on in there. They may be on POs or topicals, potentially. Sorry, looking at all this stuff here. You can use lidocaine. Some of the things actually have lidocaine to help with pain and all of that. Teaching mouth care after each meal. We want somebody to rinse their mouth out because, again, we have potential for infection. So we don't want something getting lodged in an ulcer. You know, if a person has canker sores or whatever, lodged in an ulcer and then essentially forming an abscess and becoming infected. So they should use a soft bristle toothbrush, right? Soft brush to brush because we don't want them causing damage. But we do want them to rinse afterwards. And they can actually use like warm saline or baking soda, you know, mix baking soda and water. That's a nice gentle cleaning. A lot of these toothpastes these days have like whitening, which is peroxide usually, a peroxide based, and that can burn. Okay, that can irritate things even further. So we would pretty much recommend using something like warm salt and water, baking soda, warm baking soda and water, and you can also get lemon glycerin swabs. Anything that has alcohol in it, though, any type of alcohol is going to be irritating. And if they wear dentures, we want to make sure that those dentures are fitting correctly and not causing any rubbing points where they may cause an ulceration also. And then dietary choices. We want things that are high in protein and vitamin C because that helps with healing. But at the same time, we don't want anything spicy, salty, hot, hard, or acidic, or anything with sharp edges. So like no rock candy, if you know what rock candy is. It's crystallized sugar, but anything that could like tear up your mouth or cause further irritation. When we're talking GI, always think about the irritation factor of things because we're dealing with whether it's the mouth or the bowel or the gut, you're dealing with inflamed things. So we always go with non-irritating. This is about hiatal hernia. Remember that we can see a hiatal hernia with an EGD. They do a barium swallow with that. Is the gold standard. Hiatal hernia occurs when a portion of the stomach protrudes upwards through the esophagus. So that can be irritating when people are eating, right? They can get like almost like a gagging feeling. They're going to have heartburn, regurgitation, dysphagia. I did not know this was a thing, but eructation is the medical word for belching. So you're welcome. Also, they may have chest pain related to that, kind of, but that like heartburn chest pain. So diagnostics, that EGD with a barium swallow, meds, all of our meds for GI stuff are pretty much the same. If we want to calm down the stomach, don't forget that the stomach has acid, right? That's what it's doing. It's producing acid to keep us safe from bacteria and whatnot, and also to break down all our foods. So, but acid is super irritating. So if the mucus lining is irritated, we need to calm down that acid production. So you're going to use antacids, Mylanta, Maalox, Rolaids, Tums, all that sort of stuff. PPIs, H2 receptor antagonists, all of that stuff for GERD. Now, one of the interesting things, a surgical option for GERD and a hiatal hernia, especially if we can't get that GERD to stop, all right, is a Nissen fundoplication. So what they do is they actually pull around like the bottom of the stomach, wrap it around the esophageal sphincter to reinforce it, okay? Because the problem is that acid is getting up that esophageal sphincter. That sphincter should be stopping that acid from regurgitating, coming back up, and it's not. So they use a part of the stomach to go in, stabilize that sphincter, make it a little bit stronger, and then hopefully stop that acid from regurgitating. That's a Nissen fundoplication. This is a safety alert on slide 18. Gastrointestinal and cardiac symptoms are similar. Remember we just talked about like the chest pain related to the hiatal hernia and GERD. It is important to assess the patient, notify the healthcare provider, and perform an ECG if the patient complains of chest pain or shortness of breath. Furthermore, patients with hiatal hernia may experience cardiac arrhythmias due to extra cardiac mass intruding on the atrial cavity that manifests as gastrothorax that, if left untreated, can cause a cardiac arrest. Therefore, it is important to understand the hernia may cause cardiac symptoms that must not be ignored. So basically what this comes down to is even if we're treating somebody for GERD, we know they have GERD, we're expecting them to have chest pain related to GERD, maybe that hiatal hernia, you still never want to ignore cardiac symptoms. If your person is like, ugh, I have chest pain, right? Even if you're like, dude, you just ate a triple-decker burger with all the things on it, even though we told you not to, right? You check out cardiac symptoms, okay? And that would be getting an ECG, notifying the physician. Physician's going to order an ECG. So RN considerations related to hiatal hernia, breathlessness, feeling of suffocation, chest pain, palpitations, dysphagia, eructation. Again, that's a vomit burp, okay? A belch or a verp, eructation. Don't tell me you didn't learn something new. Actions, med management, positioning. We don't want our people with GERD laying flat, all right? That just gives more opportunity for that acid to reflux up. We want gravity to be our friend. So we sit people up, head of bed at least 30 degrees, especially after eating. Teaching, as usual, nutritional considerations. Eat at least 2 hours before laying down, and then non-restrictive clothing. Risk factors. So now we're moving on to GERD. Risk factors, if you have a hiatal hernia, you're more likely to experience GERD. If you have any loss of esophageal motility, eating large meals, continuously stuffing yourself, you're more likely to have that reflux. Remember that it's the acid coming back up, right? If you have delayed emptying of gastric contents. These days, that's our Ozempic, people. Delayed emptying of gastric contents, because Ozempic and all of those meds, what are they, GLP-1s, slow everything down. That's why people aren't hungry, because it's slowing down the process. But the problem is that it can lead to GERD. Obesity, pregnancy, tight belts or girdles can lead to GERD. You know, we're squishing our insides, and so you can have reflux. An NG tube can lead to reflux. And then tobacco use, actually. So diagnostics are EGD, and don't forget, if our person says they have chest pain, we're going to believe them and work up that CV, you know, so EKG, all that stuff. Meds, same as usual, antacids, PPIs, prokinetics to increase gastric emptying. Prokinetics get that stomach to work a little bit faster. So if our person, you know, their problem is eating large meals, right? If they just can't seem to stop eating large meals, you're going to put them on a prokinetic, which helps the stomach digest a little bit faster. And then again, with our GERD, our surgical intervention would be the Nissen fundoplication. So slide 21, I want you guys to look at this. This is post-op patient ed after a lap Nissen fundoplication, all right? So it talks about diet, following a soft diet for about 1 week. Make sure that your swallowing is back to normal. Avoid foods that are not easy to swallow. Take small bites and eat slowly, right? Don't stuff yourself. Let's see. Avoid activities that cause air to be swallowed. Avoid carbonated beverages, sucking on sweets, chewing gum, using a straw. We don't want to fill that gut with air. It's a lot of pressure. Notify healthcare provider for chest pain, difficulty breathing, any of that gets worse. Continue using anti-reflux meds. Driving is allowed after 1 week and after narcotic pain meds have been discontinued. So we don't want you driving on oxy, all right? Walking, we learn all the time about how good ambulation is for you because it gets all the things moving. So walking is encouraged, no heavy lifting. Walking and no heavy lifting, general things after any sort of these GI procedures. So take a look at this. All right, it talks about wound care. It talks about reporting signs and symptoms of infection. Um, let's see. That's pretty much it. All right. Seek medical care emergently for any of the following. So, feeling very full or inability to vomit or burp. Okay. Um, you should be able to burp. Air should be moving. We would worry about strictures at this point. Thick drainage that has a foul odor coming from incisions, right? So infection. Further difficulty swallowing, abdomen that feels hard and painful, that can be infection, that can be ascites. Gauze that becomes soaked with blood, right? After something like this, we don't expect something to be bleeding that heavily. Stools that are black, bloody, or tarry, so lower GI bleed or upper GI bleed, vomiting up blood, that whole coffee ground emesis thing, difficulty breathing, feeling lightheaded, coughing up blood, hemoptysis, right? Never a good thing. New chest pain, or an arm or leg that is painful, swollen, warm, and red. That we are worried about cellulitis related to that, and we are worried about the heart. RN considerations for GERD. So actions, respiratory, right? Chest pain, hemorrhage, dysphagia, adenophagia, which is painful swallowing, nausea, belching, assessment, med management, really. Teaching, avoid the irritating foods, alcohol, caffeine, spicy things. No NSAIDs or aspirin because we're worried about bleeding risk. Eat at least 2 hours before bed and maintain an ideal body weight. All right, oral cancer. So let's see, oral cancers account for 25% of all head and neck cancers. Patients who survive 5 to 10 years have a 20 times higher risk of developing a second cancer. Isn't that crazy? Let's see, there's some staging stuff in here. You do not need to know your staging stuff. Risk factors, tobacco use, absolutely. Alcohol, habitual alcohol. So not just having a couple drinks on the weekend, but if you have a fifth every day, right? Poor oral hygiene. Mechanical irritation from dental appliances. So like poor fitting dentures, all of that stuff. Mouthwash with high alcohol content. Chewing betel nuts. We actually had to look this up. Apparently, this is something in the Philippines, and they chew betel nuts come from some plant in the Philippines, but chewing betel nut actually has a high cancer risk related to it. So this would be like a cultural consideration sort of thing. And then, of course, herpes simplex 1 or 2, honestly, and HPV. All of those can have cancer risks. So clinical manifestations usually affects the floor of the mouth or the tongue, usually asymptomatic at first. But as the disease process rolls on, you're going to see oral bleeding, maybe raised areas. Some of the pictures I saw almost look like canker or cold sores, right? But they like don't go away and they look more ulcery than a canker sore or a herpes. White or red patches that don't go away. If our person's having difficulty speaking or dysphagia, we're going to want to see what's going on. The other thing is loose fitting dentures. Because maybe our person's not eating, maybe the mouth has changed, they have ulcers, and so dentures are fitting weird. That can be an indication that something going on. Medical management, we're talking cancer. So medical management is going to be dependent on the size, location, and stage of the cancer. and then, of course, the general overall health of the patient themselves. So assessment, see how you can see in this picture, if you're looking at the slide, slide 25, the picture of that tongue, that almost looks like a canker sore or something, right? But so assessments, ability to swallow fluids, because we're worried about dehydration, we're worried about nutrition, weight loss, psychosocial adjustment. I've worked with patients before who had cancer, mandibular cancer, and so they had to go out, remove part of the jaw. And I did not get in report, I still remember it, I did not get in report that she had had part of her jaw removed. And holy cow, does that look alarming. It just looks alarming because the whole face just flattens out. You don't have anything holding, creating any facial structure, and it's just crazy. So if psychosocial aspects related to this, whether you have to have part of your mouth removed, part of your jaw, whatever, that's huge psychosocial aspects. Actions, we are going to worry about airway management on these guys. Okay, you're going to want to make sure you have emergency equipment bedside just in case. Aspiration precautions, head of bed 30 to 45 degrees at all times. We're going to give meds as ordered. Our person may not be able to verbally communicate, so we're going to use whiteboards. We're going to use our little boards that have like point to the potty, point to the phone, whatever it may be, right? Just make sure that we can communicate with our person. They may have pain, anxiety, all of that stuff. Um, we are definitely going to be worried about nutrition and weight. Um, let's see, lymph nodes, right? We're going to assess lymph nodes because if we are talking cancer here, has anything tried to migrate? Education, aspiration risk, stop smoking, oral hygiene, um, xerostomia management, which is related to reduced saliva production. So if the mouth is dry, our person is at risk for more ulcers, more breakdown, because our mouth should remain moist for everything to function and not get irritated. Our person may be on steroids, so we're going to want to talk about if they're on inhaled steroids, rinsing the mouth, all of that stuff. Teaching, let's see, talked about that. Let's see. All right, so that's all of that. All right. So nothing too crazy. Just remember that the mouth likes to be moist all the time, and this person is going to have sores in their mouth. So we have to think about what we can put into the mouth to help ease that pain, and also is our person eating and getting enough nutrients. This may be our person who we put on Ensure, right? Like a protein drink of some sort, because it's easier to swallow. It would also be cooling, like a shake, something cold would feel nice. All right. All right, so we're moving on to oral trauma. So oral trauma includes injury to specific bones of the face. This can be nasal, mandibular, maxillary fractures, soft tissue injuries, around the mouth. Severity of injuries range from minor soft tissue to complicated fractures, and usually the result of blunt or penetrating injuries. So, think motor vehicle accidents, think getting in fights, that sort of stuff. The book also talks about like athletic activities like boxing, basketball, baseball, somewhere where you could be hit with something or by someone. Clinical manifestations. So increased respiratory rate. Stridor, we're going to want to worry about stridor because what damage has been done to our esophageal area, and do we have inflammation going on? And of course, if we hear stridor, we want that emergency equipment at bedside because we're worried about that person being able to maintain their airway. We're worried about if they have decreased O2 saturation, We are worried about hypercarbia, which is elevated levels of carbon dioxide. We talked about that related to like our COPD patients when we did respiratory. But if anytime my person is not exchanging oxygen and CO2 has impaired gas exchange, I worry about the body holding on to CO2. All right. We're gonna monitor changes in level of consciousness, bleeding, swelling and edema, and loss of teeth and pain. Um, Treatment. This is going to be emergency management, right? Our biggest thing is going to be our ABCs. How is that airway? Can they maintain that airway? Do I see swelling of the tongue? If I see swelling of the tongue, my first thought is that that tongue could swell up and occlude my airway, right? So fair chance they're going to intubate, all right? You're going to be wanting to suction secretions. Make sure we don't have aspirate. Controlling bleeding. They may not even be able to intubate, depending upon what's going on up here, how bad the trauma is, they may have to do an emergency trach. They may have to bypass this whole thing because they can't either oral or nasally intubate and go straight to a trach, right? So that's possible with this. Diagnostics, obviously we're going to be looking at blood. They're going to do x-rays. They may do a facial CT or MRI depending upon what they want to see, okay? And then we're going to do an ABG because is our person oxygenating adequately? What's going on with them? Sometimes after these traumatic facial traumas, they will wire the jaw shut. Okay, I've also dealt with this person before. It's super interesting. So we are always worried about airway compromise with these people though. And can they manage their saliva, and what happens if they puke? Okay, can they manage all those secretions? And if they puke, what do we do? So the patient cannot open their mouth because of the wiring. So one of the things is you have wire cutters taped to the wall. You don't put them in a basket. You don't put them on the nightstand. You tape them to the wall, probably right next to the rapid response button would not be a bad idea, because we need to be able to cut those wires if we need to do any life-saving whatever. All right. So wire cutters taped to the wall for people who have their jaw wired shut. If we send them home with a jaw wired shut, which it's possible, you need to stress the importance of them having those wire cutters where they can get to them. All right. So RN considerations related to oral trauma, we're going to be looking at that. We're going to think about that airway. We're going to think about infection. We're going to be looking at labs, electrolytes related to nutrition, daily weights. Are they maintaining their weight? Are they getting all the things they need? We want to make sure they have wire cutters. They may be on humidification to help keep that oral mucosa nice and moist and not drying out. If we send them home, they want to do mouth care after each meal. We don't want anything sitting in there potentially causing an abscess, an infection, anything like that. So we want to teach them about signs and symptoms of infection. And then like we talked about, having those wire cutters available. Esophageal cancer, RN considerations. So a lot of times this is going to be our drinkers, right? Esophageal cancer, very much related to drinking. And then of course, cigarette smoking, anything like that. So we are worried about strictures. We're worried about GERD, poor diet. All of that is going to play into risk factors for esophageal cancer. We're going to do a barium swallow, endoscopy, maybe a CT. This is our person. Remember we talked about somebody like laryngitis versus a cancer where laryngitis resolves in like 4 days, right? But our person may be hoarse for like 2 weeks, anything more than 2 weeks, we start worrying about what's going on structurally. So it could be cancers, it could, obstructions or anything like that. Um, so we're going to look at, are they hoarse? Do they have a cough? Are we worried about aspiration with them? Do they have fistula formation? Tracheoesophageal fistula is not, I mean, it's not common per se, but it can happen. You can see it. And don't forget, a fistula is an opening between two structures that should not be there. So you have an opening between the trachea and the esophagus, right? And that shouldn't be there. And so that can be a problem, obviously. Also, does our patient have trouble swallowing? This was interesting on this one. This is dysphagia and hiccups together. Difficulty swallowing progressively increases over a few months. Patients will usually eat softer foods as the dysphagia starts. They may avoid meat, bread, and raw vegetables because these foods get stuck in the throat more easily. Eventually, liquids can become difficult to swallow. So the hiccups come from the fact that they're swallowing more air, right? We're going to look at all of our labs. We're going to look to see if our person is jaundice, okay? Do they have anything involving the liver that we may be worried about? Head of bed with all of these, 30 to 45 degrees. Emergency stuff at the bedside. We're worried about them aspirating and not being able to maintain their airway. This is another one where we go with like those 6 smaller meals a day. We don't want them eating a whole bunch, okay? We don't want them stuffing themselves. It's painful. They may aspirate. All sorts of things related to this. So 6 small meals a day. We may want them to collaborate with speech and language pathology to help with some things. We're going to do pre-op teaching if they're going in for esophageal surgery. They need to stop smoking 2 to 4 weeks before the surgery. Okay? 2 to 4 weeks before the surgery, they need to stop smoking. What do you think the compliance is related to that, right? But this is going to improve respiratory outcomes, all of that. Let's see. A lot of times after GI surgeries, even something like this, we may place an NG tube to help with decompression in the stomach. So that may be a thing. They may be on liquid diet for a while, up to 3 weeks after surgery. We're going to do dental screenings because we want to make sure that they don't have any infection going on, any abscesses, or any loose teeth, because we would worry about that. All right. There we go. All right. Esophageal trauma. Most common causes of esophageal trauma are from diagnostic, so that's us, right? Sticking tubes down people. And therapeutic interventions related to passing endoscopic instruments through the esophagus. RN considerations, low wall intermittent suction, so an NG tube, NPO. We're going to worry about nutrition afterwards. We're going to worry about signs and symptoms of infection and patient weight related to malnutrition potentially, right? So nothing too crazy about this. It kind of goes along with all of our other GI stuff. This is a safety alert, slide 31. The following procedures are contraindicated in patients who have ingested a caustic substance. So your little kids who have swallowed some sort of poison they found under the sink, something like that. You don't want to do a medic administration. So we don't want them to throw this back up. If somebody swallows bleach, we don't want them throwing the bleach back up, because as the bleach comes back up, it burns again, right? So it can cause esophageal damage. Neutralizing agents are not useful because the damage occurred on exposure to the caustic substance. NG tube insertion via blind placement can lead to esophageal perf or induce vomiting and can cause re-exposure to the caustic substance. So you would use a scope basically for anything that you're placing. You want visual confirmation of how and where you're placing something. Activated charcoal not beneficial and can interfere with endoscopic testing. So basically, if we give the person charcoal, we then may go in with our scope to see what's going on and not be able to see anything because the charcoal's in the way. All right, stomach disorders, chapter 57. All right, so we're talking about gastritis. So inflammation of the gut. All right, localized or patchy inflammation of the gastric mucosa. It can be acute or chronic, right? So it can last several hours to a few days, or chronic resulting from repeat exposures to irritating agents. So we're going to think our drinkers again, right? Most common cause of gastritis, though, is actually H. pylori. Um, Other causes include alcohol, NSAIDs, Crohn's disease, TB, and bile reflux. So H. pylori infection, which is prevalent in approximately half of the world's population, is known to be a key cause of chronic gastric inflammation that progresses to atrophy characterized by total loss of fundal glands, minimal inflammation, thinning of the gastric mucosa, leading to atrophy and abnormal cellular changes. These alterations can lead to peptic ulcers and gastric cancer. Combination of bacterial factors, environmental insults, so smoking or drinking, and the host immune response that drives the initiation and progression of mucosal atrophy, metaplasia, and dysplasia leads to gastric cancer. So our clinical presentation associated with damage to the gastric mucosa, epigastric pain, nausea, vomiting, weight loss, decreased appetite, and then again our changes in stool color. All right. Our person may have pain when they ingest spicy foods, um, um, anything irritating, our caffeine, alcohol, anything like that. Our person could be dehydrated. There could be signs of upper GI bleed. So we would want to look for signs and symptoms of like hypovolemic shock if we're worried about the bleeding, which is pallor, tachycardia, and hypotension. Okay. Diagnosis, upper GI series, x-rays, endo, tissue, histological. That just means we're going to look at the tissues. Um, Let's see. If hemorrhage is suspected, we're going to do an occult stool sample. Treatment is going to be collaborative care. So we want supportive care for relieving the clinical manifestations, but we also want to remove the causative agent. So if our person has gastritis, stop eating spicy foods, don't drink alcohol, stop the caffeine, blah, 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 right? All of that stuff. GI rest should be provided for about 6 to 12 hours of NPO status. So we want to give the gut a moment to calm down, okay? And then what you do is you like slowly reintroduce clear liquids. So that's like broth, tea, gelatin. Believe it or not, you can do carbonated beverages. And then you kind of go to heavier liquids. So cream soups, puddings, milk, that sort of thing. And you just kind of gradually reintroduce foods, but stay away from caffeine, spiciness, alcohol, all of that. Um, if anytime our person has nausea and vomiting, we worry about hypovolemia and electrolyte balance, right? So we may be doing electrolyte replacement, we may be using IV fluids. Your meds are going to be directed at reducing pain and discomfort. So, Zofran for nausea and vomiting, antacids, maybe some pain relievers, maybe, but really like PPIs, H2 receptor antagonists, that sort of thing. So our priority problems, maybe anxiety related to treatment, right? And they may not know what's been causing this in their diet. They may not know. And then we're going to worry about hypovolemia. Our assessments are going to include vitals because we are worried about fluid loss. We want the history of presenting signs and symptoms. Like, do they have heartburn, indigestion, nausea? Did they have vomiting, right? Dyspepsia, which is heartburn, okay? Do they take regular aspirin, regular NSAIDs? Do they drink on a regular basis? Gastritis, don't forget, can also be caused by endotoxins related to food poisoning. So was there an acute onset of this? Did it happen all of a sudden? Because that really could indicate a food poisoning. Also, we're going to want to see if our person has H. pylori. Because the cool thing about if it's H. pylori, then we just give antibiotics, right? We're going to worry about I's and O's. So we're going to give all of our meds as ordered. Teaching is going to be related to meds. Looking for signs and symptoms of blood in like either vomit or stool, right? Take meds as prescribed. What triggers the gastritis? You know, you may have somebody do a food journal. Like, oh, every time I drink 7 margaritas and have, you know, I don't know, Mexican food, whatever, you know, at the spiciest place in town, I end up with gastritis, right? Maybe you shouldn't do that. And that's it. And then again, we're going to do that diet where we keep our person NPO for 6 to 12 hours, and then you slowly reintroduce food, right? All right, gastroenteritis. So this is normally called like traveler's diarrhea is what we call this, but this is also like food poisoning, okay? So it's self-limiting illness. It's going to happen. It resolves quickly. Inflammation of the lining of the stomach and small intestines produce watery diarrhea, abdominal pain and cramping, nausea, vomiting, and sometimes a fever because your body's like, what the heck, right? Most cases are infectious. Now, gastroenteritis can occur related to the ingestion of meds and or chemical toxins. However, we usually think of it related to foodborne stuff, okay? Food poisoning. So it can be virus, bacteria, or parasite. Maybe you drank water you shouldn't have. Maybe you were at a picnic and ate tuna fish sandwiches heaped with mayo that had been sitting in the sun for 4 hours, right? So that virus, bacteria, parasite. A lot of times these are transmitted fecal to oral, can happen as well. You know, is it Slide Rock every year where the water becomes infected? And that is a fecal to oral route of contamination. Norovirus is actually airborne, which is interesting. Norovirus, rotavirus, C. diff cause gastroenteritis. And then our foodborne illnesses, staph, salmonella. Salmonella is huge with our chicken. Shigella, Clostridium botulinum, which is botulism, okay? The thing with the Clostridiums, because we have Clostridium botulinum and Clostridium perfringens, they produce toxins that can affect the CNS. So we for the most part, when we talk gastroenteritis, we are thinking about like nausea and vomiting, you know, diarrhea, crazy diarrhea, maybe all of the above, right? But you can also have CNS symptoms if you have ingested something that produces an endotoxin, okay? So that's your botulism. Back in the day when people did a bunch of canning and maybe weren't as aware of the potential for botulism, people used to get botulism resulting from canning a lot. We don't hear about it quite as much. Our processes are a lot better. And even people who can at home, we know a lot more about how to do that safely. So you just don't hear about it as much. But that would have CNS ramifications. So like dizziness, paralysis even, believe it or not, all of that sort of stuff. When we are talking salmonella and campylobacter, that's like our raw and undercooked poultry, right? Chicken, salmonella, it's chicken. It can also be in seafood and unpasteurized milk. Um, let's see, salmonella, undercooked eggs. Also, salmonella, don't forget, can be reptiles, birds, or amphibians. We don't want our immunocompromised people having reptiles, birds, or amphibians related to the fact that they can carry salmonella. Shigella, person to person by fecal to oral route, or foodborne. E. coli and Clostridium species. Those are they're normal enteric flora. Remember, enteric means like your gut and your intestines, but you can have pathogenic strains. E. coli is another one. There's a strain of E. coli that can cause crazy, crazy illness. So whenever I'm pooping and vomiting, I'm worried about electrolyte imbalances. I'm worried about hypovolemia. I'm looking at my person's skin turgor. I'm worried about dehydration. I'm worried about low blood pressure related to the hypovolemia. Um, all of that stuff. Um, so our Clostridium botulinum, which can affect the nervous system, headache, tingling, numbness, blurred vision, weakness, dizziness, and paralysis. Crazy, right? Diagnosis, basically, a lot of times we're going to do a stool culture, use PCR to test that, see what we've got going on. You're also, treatment is really going to be supportive. Like if our person is hypervolemic, I'm going to replace their fluids. Um, Maybe put them on like loperamide, which is Imodium and anti-diarrheal. Now, if my person has a fever, um, if my person has a fever or the stools have blood in them and I don't suspect C. diff or E. coli, then then I can use Imodium. But if my person has a fever, which kind of indicates it's bacterial, or I have stools with blood, C. diff or E. coli, I want my person to poop it out. So I don't want to give them Imodium. I don't want to stop up that process. Remember, when the body decides to have crazy diarrhea and vomiting, it is because the body is like, I need this out right now. Like when you have food poisoning, if you've ever had food poisoning, it is pretty quick, and all of a sudden you're like, all the things are coming out, right? And that's literally your body going, nope, this needs to go. So we don't necessarily want to stop the vomiting um, and diarrhea if there's certain things going on. We want the body to just get rid of it. But we do worry about electrolyte imbalances. So again, with this, we're going to slowly reintroduce foods. You know, the system just kind of blew up. We don't want to put heavy things on it. We want to avoid caffeine. We want to avoid milk. Our person should take slow sips of things, that sort of thing. So our priority problems related to gastroenteritis, possibly pain. You know, if your stomach is cramping like that, definitely pain. We're worried about that diarrhea related to hypovolemia um, and electrolyte imbalances. We're worried about nutritional status, the toxins that may have been ingested. Our assessments, obviously, we're going to do vitals, maybe even orthostatics, just to see is our person depleted. We're worried about dehydration. Tachycardia with hypotension indicates hypovolemia. All right, so fast heart, low fluid, hypotension, because remember, the heart is working harder to move around what little fluid we do have. All right, so we're not going to want to let this person like walk to the bathroom unattended. We are worried about that hypotension. We're worried about them being dizzy. Um, you want to assess the abdomen. Is the abdomen distended? If it is distended, we may want to think about a nasogastric to low wall suction to help pull some of that stuff out, get some of the acid out, get some of the gases out, right? We're going to listen to bowel sounds. We would expect our bowel sounds to be hyperactive. We're going to monitor serum electrolytes. We're going to monitor fluids. We are going to worry about skin breakdown. If my person has had diarrhea, there's a fair chance they could have, some sort of like dermatitis situation going on where that skin gets really raw and irritated. We're going to think about hand hygiene, okay? And don't forget, if we are C. diff or norovirus, that's hand washing with soap and water on the way out. Meds as ordered, clear liquid rehydration. Let's see. So teaching, same idea. Dietary modifications, hand hygiene, proper food prep. Do not take mayo-based products to a picnic and let them sit in the sun for 6 hours, right? You're going to want to think about all those things. Let's see. Swimmers, avoid swallowing water when you swim, especially if this is out in some public place or someplace like Slide Rock, because you never know who pooped in the water. You're welcome. All right, peptic ulcer disease. Peptic ulcer disease is used, the term is used broadly to include ulcerations and erosions in the lower esophagus, stomach, and duodenum from a variety of causes. This is because pepsin, which is a proteolytic and acidic solution, plays a major role in causing the mucosal breakdown, regardless of the cause of the provoking agent. So it could be related to H. pylori, cigarettes, NSAIDs, whatever. So a lot of times you'll have duodenal ulcers or gastric ulcers, all right? Duodenal ulcers actually make up about 80% of peptic ulcers. Let's see, and they're characterized by remission, so they'll come back in exacerbations. So they will do surgery related to these on about 5 to 10% of patients. Chronic gastric ulcers tend to occur in the lesser curvature of the stomach near the pylorus. All right. So peptic ulcers occur mainly in the gastroduodenal mucosa because this tissue cannot withstand the digestive action of gastric acid, which remember is hydrochloric acid, right? That's pretty crazy acid. And pepsin. So erosions result from the corrosive action of acidic gastric juice on a vulnerable epithelium caused by an imbalance between mucosal defenses and an acid peptic injury. A damaged mucosa cannot secrete enough mucus to act as a barrier against gastric acid. So clinical manifestations of PUD gonna depend on the ulcer location and the patient age. So you may have few or no clinical manifestations, but most of the time your person is going to have pain, all right? They're going to have like a burning epigastric pain, which is aggravated by either fasting and improves with food or antacids, all right? So when they don't eat, it's aggravated by fasting, and think about that. If it's being aggravated by the acid in the stomach, it makes sense that fasting would be an aggravating factor because we don't have anything else in the stomach soaking up that acid. So then when we eat, it helps it because now there's something else soaking up that acid. All right. And then if we take antacids, those neutralize the acid. So that makes sense. The pain can actually awaken the patient to sleep due to nocturnal gastric acid secretion. Now with a gastric ulcer, pain is triggered or worsened by eating. All right. So that's kind of how you differentiate. is, does it get better with eating or worse with eating? So if it gets worse with eating, that's your gastric ulcer, and you're going to get little to no relief from antacids. We're going to do an EGD. We're going to look for ulcers. Um, let's see, we're going to do CBC, all of that stuff, just see what's going on, see if you're bleeding, anything like that. Meds, pain relief, ulcer healing. We want to try to prevent ulcer recurrence. Um, if you have H. pylori, we're going to put you on antibiotics. We are going to reduce your NSAIDs and aspirins, if not avoid them altogether. Again, avoiding spices, alcohol, and caffeine, 6 small meals a day, discourage cigarette smoking, all of that. This is some safety alerts, slide 38. Do not make assumptions about pain. Acute pain may be indicative of a complication, such as a perforation, sudden intense epigastric pain, and rigid abdominal muscles, or it may be totally unrelated to PUD. So it could be like pancreatitis, it could be heart disease, gallbladder. The nurse needs to ensure a comprehensive evaluation of the pain, particularly with an acute onset. Remember, anytime we have an acute onset of pain, it is the body throwing up a red flag, right? Something is wrong. So what this is basically warning against is not jumping to conclusions too quickly. That the pain is just related to like a gastro something. You want to do a full workup in case there's something more going on. There's also a safety alert that says it is an emergency if a patient has sudden intense abdominal pain that radiates to the shoulder or pelvic area, demonstrates abdominal guarding, and if the abdomen is bloated, firm, and tender to the touch. This strongly suggests a perforation, and the patient may need to have immediate surgery. Um, so this is an important one, all right? Because a perforation, anytime we have a perforation, gastric contents are seeping into the rest of the body. Gastric contents and anything in the bowel is contained for a reason. So if it seeps out, your person can go septic on you super quick, right? And that is, of course, a medical emergency. So assessments related to peptic ulcer disease, identify your risk factors, again with the food diary, abdominal assessment, bowel sounds. We're going to do labs for occult blood. We're going to look for signs and symptoms of dehydration. And we're going to talk about the pain, like quality, location, aggravating factors, all of that. Teaching really going to be related to meds as prescribed. Avoid eating 2 hours before bed. Avoid NSAIDs and aspirin. And of course, no spicy foods, caffeine, or alcohol. Gastric cancer. Again, this is a cancer. Our treatment is going to be based on size, location, the person, all of that. Our signs and symptoms. So the person can be asymptomatic, but we could see stuff like indigestion, anorexia, small a, so they just don't feel like eating, weight loss, epigastric pain, vomiting, and then kind of like that ulcer pain, right? So burning. Diagnosis, barium studies, endoscopy, cytology, treatment. Talked about that. It's gonna depend on the type of cancer, where it is. We're probably gonna give antiemetics, opioids for pain are appropriate. Um, and that was pretty much it on that. All right, moving on to dumping syndrome. So this one you definitely want to know. It's slide 41. So dumping syndrome is associated with partial gastrectomy related to stomach cancers or weight loss surgery. It's that gastric bypass surgery, right, where they take out part of the stomach. So what happens, because we've removed some of the stomach and maybe some of the intestines, is everything doesn't absorb the way that it should. So you end up with rapid emptying of the small intestine. And this ends up feeling like almost like a food poisoning, where it just hits all of a sudden. You're sweating, you have crazy diarrhea, crazy vomiting, all the things. Early clinical manifestations, 15 to 30 minutes after a meal. Your person may be dizzy, they may be tachycardic, pallor, palpitations. You have a swift movement of fluid in the body, right? Swift movement. So it kind of throws everything off balance. You can have later dumping, which is like 1 to 3 hours after a meal. This you can go hypoglycemic, and then so you end up with the signs and symptoms related to hypoglycemia, which are also weakness, sweating, and dizziness. So kind of same deal. But really, if this is happening to people, they need a nutritional consult. They are not following the recommended diet. You are supposed to eat low, very low sugar, very low carbs. You are supposed to, liquids and solids are taken at separate times instead of together. Um, let's see, all of these things. But the biggest thing with this, if a person is experiencing dumping syndrome, they need a nutritional consult because they are not following the recommended diet, period. All right, gastric cancer, assessment. We threw dumping syndrome is in there related to gastric cancer because with gastric cancer, part of the stomach can be removed. Okay, so anytime we have part of the stomach being removed, you can end up with dumping syndrome. All right, so that's why that slide is stuck right in there. So our RN considerations related to gastric cancer. Signs and symptoms. What's our abdomen doing? We're going to look for signs and symptoms of METs, right? How are our lymph nodes? Labs. Signs and symptoms of dumping syndrome. Potentially end of life care with this, right? Palliative care. Actions. We're going to want to talk about diet, signs and symptoms management. You're going to teach about nutritional supplements, following the diet, avoiding high sugar foods, all of that stuff. All right, slide 43, obesity in adult patients. So obesity is associated with serious complications, including type 2 diabetes, cardiovascular disease, stroke, cancers, end-stage renal disease. Annual medical costs for obese adults in the US is approximately $2,505 per person more per year than somebody who has a BMI under 30. Um, Obesity causes a decrease in life expectancy. It increases mortality risk. Um, let's see. In the US, the all-cause mortality rate is 20% higher in adults with obesity compared to adults with normal weight. So, obesity really can have implications related to your health status, right? It can exacerbate things, it can impede recovery. If something happens, a healthy weight person, especially a person who's physically fit, is likely to have a much better recovery than somebody who's overweight and out of shape, right? Because the body is in a better starting out point. One of the things we always worry about with obese people is cardiac health. So we're going to get an ECG. And there's lots of things to consider related to being overweight, especially, in lab the other day, we were talking about, like 500-pound plus people. And, your landmarks on the body may be off. So when you go to place an ECG, it may look like there's abnormalities, but your pads may not be in the correct place because the body mass is so big. Sometimes, like, your person can't fit in an MRI is a thing. Maybe they can't go to CT. Typically radiographic tables The weight limit is 300 to 450 pounds, and we absolutely have people bigger than that, right? Um, Also, we talk about, moving these people. You have to make sure that you have a Hoyer lift that can accommodate. If you have to transfer your person, you have to make sure that the transfer team is aware that their gurney can fit them. That, a lot of times these days, because there's hydraulics on gurneys, um, or transfer gurneys, they may send one person to transfer someone. It could be a one person transfer, but with somebody this big, that's not safe. So you have to make sure that whatever transfer team you have coming knows that this person is overweight, um, severely overweight, I should say, and is going to need extra people. If we are moving people from a gurney to a bed, it's going to be an all hands on deck situation to safely do that, right? Um, at the hospital I was at, we always, we tried to sit people up at the bedside in a Cadillac chair, so um, a medical chair for people that sits them up and that whole thing. But we had to have bariatric chairs, because you couldn't fit these people. The seatbelts wouldn't work, and um, the hydraulic mechanisms would not work because the person was too heavy. So it's a huge thing. Pharmacotherapy, right? A person with a BMI greater than 30, you always worry about, you have to think about meds. Um, let's see. And then this talks about too, anybody with a BMI equal to or greater than 40 really should consider bariatric surgery per our book. And a BMI of 35 to 39 if your person has comorbidities. Just because a significant weight loss can greatly improve those comorbidities and overall improve health. Here's some safety alerts for you. Never insert or reposition a nasogastric or orogastric tube on a patient who has had bariatric surgery because it can disrupt the suture line. So that's good to think about. Tachycardia, fever, hypotension, and abdominal pain should be reported immediately because they may be signs and symptoms of an anastomosis leak, a life-threatening complication associated with infection and sepsis. So it's almost like a perforation, except that it's tiny little leaks, right? So again, that gastric content or that bowel content is leaking into the system where it never should be, right? So our RN considerations related to obese adults slash bariatric surgery, we were talking about this in lab also. When you are caring for someone who's this big, you need to inspect those skin folds because they can have infection, they can have yeast, they can have breakdown, all sorts of things going on in those skin folds. Especially consider the back, where if the person does not have a caregiver at home, and maybe they shower or they sweat and cannot adequately clean and dry that area, that is a huge risk for breakdown. Um, Actions, again, we're going to want to make sure we have appropriately sized equipment. So if you're getting or giving report on somebody, you always want to make sure that you give whomever a heads up that this person is 400 pounds or over, because we need to think about equipment. Also, lifting restrictions. How are we going to move this person? How are we going to ambulate them? Have meds been correctly titrated related to how big these people are? And then, of course, signs and symptoms of dumping syndrome, and maybe support groups. Maybe a little extra help, might be nice for them. Maybe that's something they need. Maybe they are open to teaching, especially if your person has had bariatric surgery. Just because you have surgery does not mean it's an easy road, right? They have diet restrictions. They're going to have health problems. A big thing after bariatric surgery is malnutrition because your stomach is so small, right? You really need to make sure that you are eating nutritionally dense foods, because you're going to be malnourished. You know, I don't know if you guys have ever seen the show, what is it, 600 pound sisters or 1,000 pound sisters, sorry. But after the one sister had her bariatric surgery, you know, her hair looked so scratchy and thin and dry. And that's related to the malnutrition that is experienced essentially after bariatric surgery, right? Because your stomach's so small, you're not eating nutritionally all the things you should. So that's a big consideration, and support groups would help with that. All right, that concludes GI 8A. Thank you.